Great. So to get us started, I just wanted to introduce our wonderful speakers. You got their bios in the email, but Sherry Rogal is an associate professor at the University of Pittsburgh, and she's co-director of their implementation science core at their CTSI. So we have some overlap there in terms of where this group comes from. And then Caitlin Reardon is joined with us. She's a qualitative methodologist and developer of both the updated CFIR and the CFIR's outcome compendium. If you've seen that before, they're both amazing, rich expertise in using CFIR as well as developing CFIR. So we're really lucky to have them today. And so I'm going to pass it to Sherry. She's going to do a presentation for us, and we're going to leave plenty of time for Q&A for everybody at the end. And I'll just mention as well, we do have that Slido for you to put your questions in and upvote those questions. So we'll put that in the chat so we can make sure we hear from as many of you as possible. So Sherry, take it away.
Awesome. Welcome. Thank you all for spending this afternoon with Caitlin and with me. So we're really grateful for your time and your interest. I just start pretty much every talk by thanking Laura and just acknowledging her and acknowledging the original developers of CFIR, which is the Consolidated Framework for Implementation Research. And CFIR is a determinant framework, sort of like Rebecca was saying. It's our way of figuring out or thinking about what could be helping implementation and what could be hurting implementation. And so CFIR defines constructs across 5 domains that could influence implementation either in a positive or a negative way. And it essentially incorporates many theories and other models to explain implementation. And so the original goal was to sort of make it all, to literally consolidate the frameworks. So like implementation science itself, CFIR helps to address the many factors that link an evidence-based practice to outcomes. And I'm showing here the Proctor model for implementation science. And I'm also going to show you the new outcomes addendum, which is going to be sort of similar to some of what you're going to see on this slide. Okay, so typically, as the people on this call certainly know, we're looking at the connections between an evidence-based practice intervention or innovation, which I'll call an EBP, or sometimes called the thing by Jeff Curran, the thing that you're trying to implement, and an outcome. And of course, implementation science also focuses on the strategies that help you get there, as well as some intermediate implementation and service outcomes. And one of the things that I love about CFIR and implementation science is that it considers the context. It's all about the context, and it's all about sort of the messy middle, which is like if you saw my minivan, you would understand that this is very much why I like implementation science. So CFIR has been really influential since being published in 2009. It's been cited over 10,000 times, downloaded 300,000 times, I think. Caitlin just looked this up, and it's always in the top citations in implementation science. And what you can do with CFIR is threefold. You can consider how to develop something with implementation in mind. So thinking through sort of the implementation barriers that you may need to overcome potentially with your innovation, or things that, the way that you implement the innovation. So designing for implementation, which is sort of the newer, more complex, I would say, application. We've been working this out as we've been doing this roadshow. You can, of course, use CFIR to plan implementation. So you can look at a site, and this is what I do a lot, like working with low-performing hospitals. You talk with the people that are there about what's helping and hurting implementation, and use that information to select strategies to address those barriers. And then, of course, CFIR can be used after the fact to evaluate what got in the way of implementation when you're doing sort of your evaluation at the end. And I know we have some expertise in planning and evaluation on the call, so very excited to hear about your experiences using CFIR. So why did they do this? Everybody was so happy with CFIR and it was so widely used. And I personally was feeling a little bit betrayed when I found out that they were going to be revamping it. I'm totally just joking. You don't have to laugh though. It's okay. It's everyone's muted, so I can't hear if you're laughing or not. Okay. But the reason for doing this was part of embodying the spirit of continuous learning and the fact that implementation science was evolving over the 10-year period. And Caitlin and Laura and others really got a wealth of feedback as CFIR was being used. So they looked at 376 articles, 59 of which included feedback on CFIR, and then sent out surveys to those authors that were sort of CFIR users as well as CFIR critics and tried to figure out how to improve things. And so this, as well as some seriously high-level intellectual conversations behind closed doors, occurred over time and resulted in both the CFIR updates as well as the outcomes addendum. So we're going to talk about the outcomes addendum first. And the reason is that, and Caitlin can talk more about this at the end of the talk. The reason that this I'm talking about this first, and we're sort of that this became a really big issue was that they actually considered making implementation outcomes another domain of CFIR, because you can't really think through CFIR and you can't really think through your determinants without knowing what you're trying to implement and what outcome you're trying to address. And so the CFIR outcomes addendum addresses the issue of sometimes when you're thinking about outcomes, you're anticipating the outcomes, and sometimes you're looking back and looking at actual outcomes. And that there seems to be a lot of confusion around what is an outcome of implementation versus what is an outcome of the innovation. So what is an effectiveness outcome versus an implementation outcome? And also, what are you measuring determinants of implementation, or are you measuring determinants of your innovation? And so to sort of add some clarity around that, Caitlin and Laura and the team developed the outcomes addendum. So when thinking about implementation outcomes, and this somewhat to some extent includes some of, if you're familiar with REAIM or other outcomes frameworks like the Proctor Outcomes Framework, it sort of adds on to this by adding the anticipated and actual implementation outcomes. So the anticipated implementation outcomes are indicators of anticipated success or failure. So is it adoptability, implementability, and sustainability? And then you can have actual implementation outcomes. And again, you're thinking about, where am I with this program? So you sort of want to position, what is your use case for the CFIR? Where are you with implementation? What is your primary implementation outcome of interest? And where are you trying to use CFIR? And you want to and then some of the elements of original CFIR got moved in because they were truly outcomes. They weren't really actually determinants. They were early antecedent assessments or precursors. So if you sort of think about almost like what has to happen for successful implementation, whatever the thing is needs to be acceptable, appropriate, feasible, and delivered in a favorable implementation climate that's ready for implementation. And then you can get sort of adoption, implementation, and ultimately sustainment, which ultimately will lead to improved outcomes. And those outcomes are the result of how well that innovation works, but also how well it's delivered. So the implementation outcomes are, as we all know, a result of your implementation determinants, and your innovation outcomes are a result of how well your innovation works. And sometimes there's a little bit of fuzzy overlap. But just really focusing on separating all these things out and defining them really early. And we're going to be talking a lot about that the really baseline defining stuff is a real key and can avoid some of the pitfalls that they've seen over the years with applying CFIR. And as you can see, equity is a key implementation outcome and a key innovation outcome. So we can keep talking about that, but that's another theme that you're going to see. So let's talk about updated CFIR, CFIR 2.0, new CFIR, augmented CFIR, whatever you want to call it. This is a picture that we made to sort of illustrate that the domains remain the same. The constructs have changed to some extent. And we're going to go through each of the domains and some of the subdomains and constructs while we talk, but not exhaustively through each and every one of them because there are a lot. There were some added, there were already a lot. And so we're just going to talk about big key themes, and then you can ask all your really hard questions to Caitlin at the end. Okay, so main things that happened with the updates were adding framework level and domain level guidance. So how do we really think about these things? Removing or adding some of the constructs and subconstructs and revising as well subconstructs and constructs and reorganizing and moving things around. So as you could see, some of the constructs got moved out into the outcomes addendum rather than staying, for example, in the inner or outer setting where they had been. Okay, so when we talk about framework level guidance, we're talking about how do we apply CFIR? And so one of the main questions that came up a lot, I certainly had it, Caitlin had to talk to me a lot about this to convince me, was who are we really talking to? Who are the people that we should be talking to when we're talking about CFIR, when we're asking about implementation determinants? And really, those are the people, should those be patients? Because we always want the voice of the patient, the voice of the customer, the end user, but this is not necessarily the right person to ask CFIR questions to. And I'm sure a lot of people have had this experience themselves and can speak to it. But essentially, the people that we want to talk to are individuals with power over implementation. And, also acknowledging that when we're asking people, we are, of course, getting their perspectives. So we're getting a blend of the objective reality and the subjective perceptions that arise out of the experiences within the setting. So there's an acknowledgement that this is not some absolute Aristotelian truth or something. But we know that we're collecting perceptions, and those perceptions actually influence reality. So it is also still important. And then the other thing that updated CFIR does that I really love is operationalize the subject of each domain and really focusing on project specific terms. So we don't want people to just download the whole like equivalent of the CFIR guide and just put that into their grant. We really want it to be tailored to the project and to operationalize each of the domains, as you'll see. And always, Caitlin always says this to add constructs as needed. So don't, this is not gospel. This is a working framework that we want, as is evidenced from the fact that it's been updated so much. Like everybody should tailor it to what they need and also feel free to add and make suggestions. So in terms of the domains, these are the definitions of the domains. You'll see that intervention was changed to innovation, and we can talk about that. But the definition of innovation is the thing that's being implemented. And this can be a new clinical treatment, a program, or a service. One of the innovations I use in my work is, for example, cancer screening, which isn't innovative or new, but it's something that we're focusing on improving the implementation of. So whatever your thing is, that goes in that box. So when I teach this to new learners, I have them literally write down in these boxes, define their innovation, their outer setting, which is actually defined as being outside what the inner setting is, which is the setting for implementation, or the place where you're doing the work, either the hospital or clinic, a school or classroom, or even a city, depending on your setting. And I think about the limits of the inner setting as being the units of randomization if you're doing a trial, the unit at which you could potentially change your strategies, or where you may see sort of a culture change. And then the individuals has been divided into two subdomains, roles and characteristics. And the biggest change, I would say, in CFIR has been moving all of the people into this category. So it used to be that patients were in the outer setting, and champions were part of the implementation process, but that was confusing and also probably not really taking into account the realities and all the ways that it could be. So now all of the individuals and their roles and characteristics have been moved into this domain that focuses on people who are involved with implementing, delivering, and receiving the innovation. So this is where patients are in the sense that their characteristics, their roles, and sort of all of those things is in CFIR in this area. And then the implementation process focuses on the activities and strategies that are used to implement the innovation, and really thinking about this is why it's so important to delineate that boundary between the innovation, where that ends and where this process begins. And so this is just an example from a project that we just did implementing liver cancer screening. We focused on VA hospitals. Each VA hospital was considered to be its own inner setting. And then we considered the outer setting to be the broader VA, the non-VA medical system in the US at large. And again, you see there's layers, and we'll get to that. We're going to talk about that again in a minute. And then all of the people involved, so patients, providers, administrators, program champions. And then the implementation process that was used was really, we used data-driven implementation strategies that were selected by site champions to improve HCC surveillance or screening. Okay, so you have already done a lot of hard work. You have defined what you're trying to improve, which is your outcome, your implementation outcome of interest. You have thought about where you are at baseline in terms of the stage of implementation. Are you anticipating that outcome? Are you asking people to anticipate implementation that hasn't happened? Or are you actually looking back at something that has already occurred? You have already defined all of the important domains and delineated sort of their boundaries. Okay, so now we're going to go into what's in each of these domains or the constructs. So the innovation domain, again, characteristics of the innovation, the purpose, the type of innovation, and the components, and distinguishing that innovation from the implementation strategy or strategies used to promote its adoption, implementation, and sustainment. And so again, what are the core components? What are the adaptable components? And really being really clear about what those are. And what you're going to really love is that the constructs really haven't changed much. The things that can influence implementation are really the perception of the source of the innovation. So the degree to which the innovation is perceived as coming from an internal versus an external source can influence how well it's implemented. The perception of the degree to which it's evidence-based, it's better than other things or has a relative advantage, is adaptable, trialable, complex versus simple, the characteristics of its design and its cost all play into the extent to which an innovation is implementable and the extent to which the innovation itself poses barriers to implementation. Now let's get, sorry, don't worry, I'm fine. So the individual's domain has really been completely overhauled. So just, it's okay. It'll be okay. And for new users, this is great because it's actually easier and more intuitive. So again, thinking about who are the people involved in implementation, all the way from the developers of the innovation to the patients receiving it and their families and community members. So what are all of the different roles applicable to the project or the implementation project and where they're located? Also thinking about their characteristics. And we're going to talk about that in a second. So the big change here is, again, the individual's domain now takes everybody, and the roles include everybody from leaders to recipients, as you can see on the left. On the right, you can see that the work of Susan Mickey and colleagues has been really embedded into CFIR, thinking about behavior change and characteristics of individuals and what makes them able to make a pivot or do implementation, focusing on the COM-B. Which sort of that theory says that an individual's capability, their motivation, and their opportunity come together to influence their behavior. as well as thinking about the perceptions of need. And so when you're talking to people, you're talking to them both about their own role and their own characteristics, as well as their perceptions of other people who are involved in implementation. The inner setting has been moderately changed. So again, the inner setting is the setting in which the innovation is being implemented, and you want to define it and the boundary between the inner and outer settings. And there can be multiple layers to this. That's okay. You could be talking about classrooms within a school, and I think that what's most important is that when you're asking somebody the inner setting questions. So, for example, to what extent do you think, that the culture in your classroom or the culture in your school um, is amenable to this change or this implementation effort? You want to be clear about where you define the inner setting so they can answer, because it may be that the culture, for example, in the classroom is different than that of the whole school. So before you start developing the questions, again, defining the boundary of the inner setting. So when I'm talking to people, I'm usually asking about the whole hospital, and not just one provider's clinic. So that I make sure to define that for the people that I'm talking with and get collecting information from. So, in terms of the inner setting, it's divided into two different subdomains, which I actually really like. There is, and this is based on suggestions of users, there are characteristics of the inner setting that are persistent across all implementation efforts. And it's intuitive, but it's also brilliant, I have to say, to think about there are structural characteristics, cultural characteristics, relational connections, and communications that are persistent in that setting regardless of what you're trying to do. But then there are also some characteristics of the that are differ depending on what you're trying to implement. And like for example, in VA, some of the things that I've worked on, trying to implement cancer screening is really different than trying to implement a syringe program, or a prep. Like standing up a whole new infrastructure and program in a setting is different than trying to improve a cancer screening. And so you just keeping that in mind, you can imagine that the tension for change, the compatibility, the relative priority, incentive systems, and mission alignment may be different for those different implementation efforts. Whereas again, some of the relational connections and communication are more persistent and inherent into the inner setting and stay the same over time, potentially. There's also, we also ask about available resources and then access to knowledge and information. The outer setting is, again, the characteristics of that space outside of your inner setting, and again, can be multi-layered like an onion. And, my favorite new addition is critical incidents, which focuses on, I think sort of came out of COVID, et cetera. But what are these critical sort of society-wide things that are happening that influence implementation, even though they're outside of our control necessarily? Um, Local attitudes, that doesn't mean local to the hospital. That means, sort of regional or in that outer setting, as well as conditions, partnerships and connections, policies and laws, financing, and then external pressures was built up. So it had been sort of peer pressure, if you remember, or positive peer pressure. Now it's societal pressure, market pressures, and then performance measurement pressure. We have a lot of that in healthcare, especially. And so the extent to which those things help or hinder your implementation effort. Implementation process domain also was really changed a lot for the better. So these are really when you're asking about these elements, it's the extent you're asking about the extent to which the person in the role that they're supposed to have for implementation is doing that process that they need to. So planning implementation, if they're supposed to be doing implementation, things like that. And these are the activities and strategies used to implement the innovation. So a lot of my work has focused on implementation strategies, and it's definitely really critical to distinguish between the strategy and the innovation. So for example, education is often part of a complex behavioral intervention, but and also and sometimes just key part of the innovation, but other times it's actually an implementation strategy. And so, and it doesn't matter. It can be either. It's what matters is placing it in the appropriate bucket before you start so that you make sure you're measuring the right thing. And so the implementation process domain was really built out in the newer version. And you'll see a lot of the ERIC strategies, which, ERIC was released in 2014, so about 5 years after original CFIR came out, and named and defined 73 implementation strategies or methods or techniques that could be used to support an implementation effort. And so the updates to the process domain really took some of the key elements of an implementation process, key ERIC strategies, and put them in here. But you can put whichever ones you want in here and ask about them. And that's what's beautiful about this. So here you go. Here is the picture, and we can talk a lot more about it. I just wanted to close with some of the overall pointers, which is that CFIR 2.0 really made language more consistent. So you probably have heard me saying the degree to which X is present. It's really focusing on who are the people we need to talk to in a continued way that I think CFIR always did, but really focusing on who all those individuals are. There is a more intentional link to equity, both in the outcomes addendum as well as in each of the individual constructs themselves, particularly around culture. And we can talk more about this as well. And then, really, again, if there's sort of one point I hope that's a take home is just to really define the domains early on, define also the outcomes early on, and then go in and tailor the interview guide. So Caitlin has been working really tirelessly on an updated interview guide and coding guidelines, and it's almost ready for prime time. She's been sharing it with people very generously who ask for it. We're also writing this CFIR users guide made for people like myself that just want like a practical, okay, I have 10 minutes. How do I figure this out kind of thing? Where do I start? What's the first thing I need to do? So it's a stepwise approach to sort of doing the things that we've talked about, like defining your outcomes, defining your domains and picking the important constructs for your project. We've been doing some psychometric testing of a CFIR 2.0 survey. So that has been really fun and interesting. We can talk more about that. And then we're using data collected over the last 10 years about implementation strategy impacts across different VA implementation efforts, and CFIR mapped data as well as CFIR survey data to inform an updated CFIR ERIC matching tool. That's sort of longer term project. So if people have data that they think may be applicable or they want to talk about or they want to be part of these, we have a big tent. We want people to come in and we want to work with and learn from all of you and appreciate your time. So for discussion, we're interested in what you think and what implications you see for your work. And thank you for your time. I'm going to stop sharing.
Thank you so much, Sherry. It was such a good overview, and I was so happy, even though I've been using this for so long, to be able to learn some new things, hearing right from you, clarified a bunch of things, really wonderful. There are some really good questions in the Slido, and I really encourage people to go in and put their questions there as well. We'll start with questions there, and then if we have time at the end, we can open it up to other people, but feel free to jump in the Slido and upvote your different questions. So I will throw them out to the different people as long as you put your name there, so you can ask your own question. And just before I do that, just letting folks know, I put this in the chat, but there will be a recording of this. You can get it through our listserv and our website in about a week after we go through accessibility. So to get us going on questions, Kamini, would you kick us off with your question?
Yeah, sure.
Thank you.
Thank you so much for sharing that and sharing the updates. I'm definitely newer to using CFIR, but I work with Becca, so she loves CFIR, therefore I know we'll use it a lot. And I'd love to hear more about the culture domain or construct specifically, because I think especially when I was first using it and kind of coding our stuff, I kept thinking like, well, what do I put in here? Culture is such a broad and big concept. I did notice I was looking through the updated guide a little bit more, and I noticed that there's now like subcontracts constructs within culture. So I just love if people can talk a little bit more about that, and especially what do you think about when you code to culture?
This is so you, Caitlin.
Thank you. So I would say that's a great question. Yes, I mean, initially culture did not have subconstructs and it was a truly just like massive construct and no one knew what to do with it. And so I'll say that when we were kind of going through feedback and thinking through our own work, we pulled out sort of 4 types of ways that we see culture show up, but that's not necessarily all of them. So again, add constructs, right? The 4 that we ended up choosing, I'll start with the first 2, my favorites actually, are sort of recipient centeredness, which in the healthcare setting would be considered patient-centered care, and then deliverer centeredness or sort of staff centered. And we think about that as the the triple aim in healthcare evolving into the quadruple aim of healthcare, which recognizes, if we don't take care of staff, then excuse me, then they can't take care of patients, right? And so is there culture, is there things showing up in the inner setting indicating that that type of culture exists? One of the other constructs is the human equality centeredness, which let me tell you, it was just a really hard construct to name, but we wanted to get at like whether or not that was a priority or part of the quote unquote culture in an inner setting. And then the last is the learning centeredness, which kind of actually gets at the example that Sherry gave about culture, where it's like, are you amenable to change and learning and improvement? Or are you sort of stuck in your ways? So a comment like they're really stuck in their ways is definitely something I would code to culture, for example. But it's still big, and I think that you'll have to just sort of like find it in your data, really when you're coding. And I'm always happy to get coding questions by email, so just
She
shoot them
really
my
is.
way.
I
I
thought she
really am.
did it.
Yeah.
She did.
Good to know. Thank you.
What a resource. Thank you. That's amazing. Julie, do you want to ask your question?
Yeah, thank you for this. This is really helpful. I think I just wanted to know a little bit more, maybe the motivation behind switching intervention to innovation. And you started to get into this a little bit after I asked my question in the Slido, but just a little bit more context on sort of maybe why, to the extent that you know why that change was made, and if there's any other implications kind of we should be aware of.
Because so many people were complaining. No. Jerry, you made me laugh and you're like, why did we have to change it? And I'm like, you were not at the time getting the emails of the complaints.
I was not.
And like the gaps, this massive oversight that, anyway. But so there was a lot of feedback. Well, it was funny. There was a lot of feedback that CFIR was both like too narrow, as well as being too abstract, which it's really hard to like be concrete and specific and not be narrow. But anyway, so, and we also have found a lot of people that wanted to use CFIR and were using CFIR outside of the like, I have an evidence-based program intervention that I'm implementing in a healthcare system, blah, blah, blah. We had lots of people in low middle income countries. We had the most like far out folks that I've ever talked to were folks that were using CFIR in farming communities. And so really just like a lot of times, they were using it to implement or to evaluate implementation of policies, of process changes. And so the word intervention really wasn't broad enough to capture all of the different uses. And so we had to sort of trade off, you'll see other language has become more generic, like recipient. People are like, why? It's like, well, because sometimes sometimes it's patients, sometimes it's students, sometimes it's farmers. So we tried to be as concrete as possible while also not narrowing CFIR to healthcare. And that was just like a tension that we had to walk the line, I guess, essentially. So that's why you've got some of that deliverer language and things like that in there now.
The tech people like it. But
I
I
know,
still say the thing, that's the most
Yeah.
generic, but you can't really, I don't know. I don't know if you could put that in a framework, but What do you think about it?
Oh, is that for me?
Yeah.
Yeah. No, I was just thinking about you know, study sections and maybe somehow them like reacting to the fact that innovation is the actual like terminology that's being used. I think I appreciate the context actually about why it's no longer intervention, because I think it actually probably helps distinguish maybe a little bit further from implementation strategy, almost a little bit too, because I think something people struggle with is what's my intervention and what's my strategy. But yeah, I was sort of just reacting to innovation, kind of aligning with the NIH criteria and whether people would have feedback about that. I think I kind of like it more, and I see why, like from a broader sense, we're moving it from the healthcare definition makes sense.
We do keep saying your innovation doesn't need to be innovative. Like it can be something you're already doing. It's just not being done well enough, you know?
Here, I haven't heard you say that yet, and I actually love that.
No.
I love that. Okay, yeah.
Oh my gosh. You know what the best thing that I heard recently was? I'm sorry, this is a total sidebar, but I think people appreciate it. So we were filming this really embarrassing video at Matt Chimman's friend's house. And you'll maybe see it. We'll post it on YouTube soon. And he was like, you know what you should say? He was like, it's so obvious. See for yourself. And I was like, how did I not ever think of that? See for yourself. It made it in the video. You guys are the first ones to know. It's like when Taylor Swift announced her new album at the Grammys. That kind of, I just dropped that.
Speak for yourself. I love that. That's great. That's really great. Okay, I'm gonna go to my question. So I'm always really concerned about the people, and I did not like the individual one before, or I just not that I didn't like it. I just always had to create like lots of new codes because the parts of the person was just not in there for the stuff I do. And so I was really interested in how you've separated out into roles and characteristics. And actually, I hadn't really understood the like theory behind the characteristics thing until today. So that was super helpful. But one thing that I'm wondering about is like, do you have any best practices or sample papers of people who have actually used that new part of CFIR 2.0 the way you hope they would? Because now it feels just like all of CFIR, like so big. It's like, oh, how many of these people like role codes am I going to use, and how many of these characteristic codes? And now that I heard about your theory, I'm like, oh, do I have to use all four? Like, or can I just focus on behavior? So I'd love any thoughts on the new individuals.
So I would say, and we'll like sort of recommend this more strongly, I think, in the coding guidelines and things like that. But to really think about it as a matrix, and you're coding, each characteristic to the specific role that's relevant if the data is showing up there, right? So it's really like, the first role is high level leaders, and then it's need, and then com, right? So it's the high level leaders need, capability, opportunity, motivation. So I think that's the first thing. That's at least our worldview, I'd say, like in the CFIR worldview, where we're thinking like the unit of analysis, right, is going to be that collective. And what I've actually so I'll fess up, I never ever coded the characteristics of individuals domain because there was so many issues with it, and it never like really captured the full story of like the person in the role who we cared about. And so I just coded everything to the person. Like, this is the person, this is everything that's relevant about them. And we're still sort of recommending doing that. And then if you want, doing a second pass through your data, so you've coded everything about high level leaders, and that can be perceptions if you are able to get them on the phone, right, to do an interview, or perceptions of them to that role itself. And then doing another pass and looking for relevant characteristics that may or may not, be the com, right, exactly. Or they may, what's wonderful about TDF is like, it maps out to so many other like discrete constructs. You might even want to bring in theory about leadership to pull out characteristics for leadership. So it's really like choose your own adventure, and be thinking about, once you've coded all of that data, what's coming out about leadership that matters? What are the characteristics that matter? And maybe those aren't any of the ones that are currently there, but we tried to be broad enough where it was like a little doorway to a bunch of other theory to think about, because like characteristics for leadership that are relevant may be very different than characteristics of your implementation leaders, right? If you're thinking about skills around project management versus skills around leadership, like those are really different, right? And, when we're thinking about need, that like we only ever had, patient needs and resources in the framework, right? And now we've kind of added that for everybody. I think most people that you talk to, like the patient need for an intervention, right, is still going to be innovation, is still going to really be probably driving a lot of people's motivation. But you do want to be careful that implementation of this new thing is not completely at odds with the needs of all of the other roles, because you're not going to have sustainment, right, if that's the case. So I feel like I never answered that in like a very clear way, but basically I would say code to the role and really see what's coming out as important in terms of the characteristics.
Great.
I thought that was super clear.
Oh, and there is nothing that I know of is published yet, but like I know of a project, a paper that was just submitted that like will sort of show that. And they have a cool example of looking at recipients being both children under 5 and their parents. So it's kind of a cool way to look at how the roles shake out and different relevant characteristics. So
Keep a lookout for that one. Yeah, wonderful. I'm going to ask one follow-up question. Please keep the questions coming in the Slido. I think we'll get to all the ones that are here, but just one more follow-up question on characteristics of individuals. One thing that has happened a lot in many of our projects is there's a lot of turnover in that particular site. And turnover a characteristic of individuals because it's like their short duration working there, or is turnover an intersetting question? That's like a question I've been wanting to ask like the developers like for years. So
I love you. No, yeah, that's such a great question. Oh, I love that. So same. We've also been like, how do we capture this, right? There was actually a project I was on with Matt Chipman where we actually coded turnover to culture because there was a culture of turnover because the folks just couldn't stay in those roles. So I do think it's going to matter how they talk about it, but I'll say two things. One, so structural characteristics now has subconstructs, and one of them is called work infrastructure. And that includes, did you put it there? Oh, yes. Oh, you're a super user. Okay. All right. I see you. So yeah, that general staffing. I would say it might blur into opportunity, right? Because if you've got turnover, you don't have adequate staffing. It's possible that the staff that are there don't have the time, aka opportunity, to do what you want them to do. But
great.
Awesome. Yeah.
Thank you. Okay, so we have a few other anonymous questions, so I'm gonna kind of go and just ask them for the group, but if I ask your question and you want to come off mute and talk more about it, please do. So there's one question here that says, does this mean that CFIR is no longer a deterministic or only framework and is a hybrid deterministic evaluative framework? I think this is related to the outcomes being added.
And there's process in there. So I have
Go for it, Sherry.
Oh no, I mean, I guess it depends. Okay, so this is now, Caitlin, you can tell me if you disagree. So I think at its heart, the goal is for it to be a determinants framework. However, I think it doesn't exist, outside of that. It's like the context for the determinants framework. You can't think about determinants if you haven't also considered sort of your outcomes, and the process is embedded. So it is, and we've had a couple of meetings where we've been with EPIS people and re-imprison people and, have sort of all presented, and it really feels like everyone is sort of converging into this like theory to unite them all. So, but I think, so I think it's a great question. I mean, I think you can just focus on, potentially just on the determinants aspect. That's really the strength. But I think there are, but I want to hear what Caitlin has to say too.
I think I agree with everything you said. Fundamentally, the CFIR and what it is intended to be used for has not changed. And the outcomes addendum was really, in part, the result of needing to address confusion about what the CFIR was and what the CFIR was not. So we got a ton of recommendations to add sort of like patient level determinants and like recommendations and confusion around, well, how do I use the CFIR with patients? And we were like, ooh, there's like just a general misunderstanding here because we're really thinking through implementation being on the delivery side, there being sort of inner setting level determinants to that, and that being really distinct from the actual lived reality of patients. And being very upset about it, right? Like, we're, I think, the first to say that, like, I truly wish that, you know, hospital level leadership was actually sharing power and decision making with patients. And if that was the case, CFIR would absolutely be appropriate to be used to collect data from patients. But I have never seen that. We're starting to see like sometimes director level, you know, sharing decision making with like providers, and we're seeing more and more providers sharing decision making, right? Shared decision making with patients, but I've never seen it like the full gamut. So part of the reason the outcomes agenda came out was to say, like, this is what the CFIR is. It is containing determinants to implementation, and it's not the end all be all. It's not everything else you need. You still need to do, we still recommend, you know, doing hybrid trials, looking at effectiveness of the intervention, but you got to do a whole different realm of data collection to get into that, essentially. So in that sense, I think we were really trying to highlight like what the scope of what the CFIR is, and that at its heart, it's a determinant framework, and whether or not, you know, you want to step outside the bounds and use it, you know, differently, if you want to go wild with the process domain and let it, you know, guide your whole implementation project, sure, but at its heart, it's for evaluation.
Mm-hmm, mm-hmm. Great, that's very helpful. There's also a question about guidelines or trainings for how to use the CFIR-ERIC matching tool. Does that exist?
No, the current tool is really just an Excel spreadsheet on the CFIR website. You can download it or request it if it's not working. I think sometimes the macros aren't working. Actually, I have never seen a website with such good response. I'm not the one responding, but I do see all the emails, and Caitlin responds to a lot of them. And then Angie is like our woman behind the scenes who does a lot of the responding. Macros are broken forever. So what you do, it's pretty simple. You basically click on the key barriers from old CFIR, and it'll give you the ratings of implementation scientists as to what they think would be the best strategies to address those barriers. But it's not based on data. It's totally expert level of evidence, you know? So like if you're thinking about like evidence, quality of evidence, right? And interestingly, one of the things that we found was that the group that made the ERIC that made the ERIC taxonomy, who we love and work with, I mean, like they're on our team. So they're wonderful. But one of the things that they did when they made the implementation strategies was they rated the extent to which, see, I'm using the extent to which, Caitlin, you've like hypnotized me or something. The extent to which they were feasible and the extent to which they would be effective. So they have this quadrants where they show the impact and effort of the strategies. And what we found through like real work in the VA was that a lot of the strategies that were thought to be or perceived by researchers to be not feasible were actually being used all the time in the real world. And so I think I would just say a little bit of the experts are experts and they're researchers, but they're not always right. So I think that the current tool is awesome. The motivation for the new tool is to add some data to that. And so if people have data from ERIC surveys or ERIC strategies and barriers that they are addressing, we did then please feel free to join our project. We did do an extensive systematic review of ERIC strategies and their impacts in experimental trials. And the data are, to be honest, a bit of a mess, but we'll include that also. But those experimental trials are very, in certain ways, not as real world as like real world observational data and what happens and across a whole system. And, so anyway, I think it's going to be a big group project to actually figure out which barriers match which well with which strategies, but the actual tool is very simple in this sense, and usable. And just
Great.
email.
We will email if we need to get it. Thank you so much. And
Yeah,
it's helpful to know, to hear a little bit more about like the data that's behind the existing tool, because I think it's kind of hard to you know, wrap your brain around that. So thanks for that background. So I'm gonna have Julie close us out because she has the best closing question that there could ever be. So go ahead, Julie.
Yeah, you've been alluding to it a little bit, but it was basically kind of what feedback on like the CFIR 2.0 you've gotten and what you would kind of make or modify for perhaps a CFIR 3.0 if you're considering that. Just sort of high level feedback or things that you kind of wish you could have done differently.
Oh, I'm like, I can't even, I can't, I just really cannot. What's wild, I don't think people realize this, is like we tried to start the updated CFIR 2.0 in 2016, but none of us were funded. And we eventually got like 1 year of like a little bit of funding to work on it, but it was always just like pulling it from other places. And it kind of is just continues to be that way. So I'm like not even at all emotionally prepared to think about 3.0 or what that would be. It's funny. I actually think I'm too close to it in some ways to get that much. Well, no, that's not true. I definitely get the feedback, and people are like, "It's so hard now." And I was just like, I kept being like, well, it's your fault. Y'all complained, and this is what you get. But what I'm hearing is that it's harder. But we'll see. Hopefully, the user guide will help. Personally, as a user, some of the things that we did I find annoying, but not, it's at like the coding level, it's not at the like conceptual level. For example, so like a lot of times you're coding strategies that they did or didn't use to engage different people, and then whether or not that person is engaged is different. So like the strategies they're using is under the process domain. Whether or not that person like gets engaged, is committed, capable, blah blah blah, is under the roles. And so it's like a lot of double coding or relationship coding. So for me, doing a lot of rapid analysis, not having software available, I'm like, I wish this was just one construct. But anyway, that's not really a change I would recommend. It's just like my little pet peeve that I've experienced lately while coding. So but yeah, Sherry, I feel like you get maybe like what feedback have you
Oh,
gotten?
well, when I first heard about it, I told you I was very upset because I am a pragmatic kind of person. I'm a doctor. I do colonoscopies. I like things to be simple-minded for myself. And so I thought it was really complicated. As I've been working with you, Caitlin, I've sort of learned how like it really is beautiful. Like, and I think it does make sense. It's just that there's a lot of different constructs. I think once people sort of hear the spiel or think about it a little more or do like these worksheets and stuff that we're putting together for the user's guide are going to make it much more usable for early users. I think for advanced users, it seems like they really like it. They like that the relational coding that you're talking about, Caitlin, and they're like, "Oh, that was clever." Like they can really appreciate, I think, some of the nuances and just all of the thought that went into each and every change is really remarkable. So I think people don't like change, as we know, as we all know as implementation people. But I do think that it makes a lot more sense. And I actually think it's easier for new people coming into it fresh, to especially the individuals component. But
So
I'm
maybe
curious.
kind of, oh, I was gonna say, can I follow on quickly on that? Is it to the point where you would almost just recommend teaching CFIR 2.0 to new users?
That's what we've been doing in our
Yeah,
implementation.
just
Yep.
like straightforward, do that. Okay, sorry, I interrupted you.
Oh, no, you're good. I think, yeah, I just actually just call it the CFIR now. Like I feel like what was and now it's gone. Like I wouldn't even like it just is it is the CFIR. I don't know how else to like say that exactly, but I think what I hope will come out, I think I came to the CFIR from like I was trained by a medical anthropologist. And so when I first saw the CFIR, I was coming from doing all like grounded theory, ethnography, and the idea of even coding with a framework was like, no, I'm not gonna do that. You know, in fact, one of the first studies I did with CFIR, we coded inductively and then mapped to CFIR, and it's one of the ways we found gaps. So I just immediately like rejected it and was like, I'm not going to do it the way it's written down. And I hope more people, I'm not like, should I be saying this out? I hope more people will feel really truly like make this work for your project, operationalize it, add constructs, get rid of constructs, you know, make the language that is so abstract now, like innovation, make it the thing that you're actually doing. Like make it so it makes sense. And don't be afraid to do that, because I think that's where like that flexibility is 100% intended. And I think it makes it a lot easier to use it. If something seems really hard, like maybe it's not right for your project, if that makes sense.
I love
Not
that.
the CFIR, not the CFIR overall. Of course, the CFIR is right for your project, but certain constructs or something like that.
I love that. I love that you're giving us permission to use it in the way that's going to work right for our project. Drop constructs, add constructs. It's our guide, but it doesn't have to be something we use fully. And that's a hard thing for people to kind of get over that hump and then realize, like, how much can I drop? How much can I add? So thank you for ending there. I think that's really helpful for everybody to hear from you guys. So thank you very much. This was a really fantastic presentation, and thank you for everybody for your really great questions. Julie, is there anything you want to say about upcoming meetings? Should I be vague? Yeah.
Yeah, I think the biggest thing is that our next, we're reaching out to potential work in progress presenters for March. So if you're interested in doing that, please reach out to myself or Caitlin Henkin or someone else on the call. And otherwise, we have some really fantastic presenters then lined up for April and May.
Wonderful. Thank you so much to our guests, and thank you all for coming today. Bye, everyone.
Thank you so
For
much.
having us.
Thank you.
Thank you. Nice to meet everybody.